Thank you everyone for coming again for our Conversations in Global Health class. John, Professor Monahan is not here tonight. He is traveling overseas, but I'm excited to welcome our guest tonight, Jeff Sturchio. And I'm going to sort of, continue our classes where we ask prominent global health professionals about their life and how they got here, and then turn to you for questions. And I'm really excited. Jeff and I met many years ago, which you probably actually don't remember, when I was just out of graduate school and working at the Center for Health and Gender Equity. So back in the day, and you've had a wonderful and interesting career working. At the head of the Global Health Council and going into private sector. But I want to, as we like to do in this class, sort of start at the beginning when you were here. So could you talk a little bit? And we're gonna Jeff had a very interesting day on Capitol Hill, so we're gonna wind to that. But can you talk a little bit about where you were in high school and what were the things that college, and the issues you were thinking about and what you were studying as you were thinking of what to do afterwards?
Well, first, thanks for inviting me. It's good to be here with all of you. And one of the things I noticed just as I look around the room is, and we could talk about this, or you may have a different point of view, but I find that these days recruitment into global health is leading to a workforce that tends to be skewed towards females for some reason, and which is good. And what I was just going to observe is that sitting here, it reminds me of being back at Rabin Martin, the little global health consulting firm I run, because we have about 40 people in New York and London, and close to 90% of them are women, and so I'm one of the few men in the entire firm. So it's been an interesting experience for me. I've been there this will be my 9th year, and that gender balance has been pretty constant through the whole period. But
why do you think that is?
Yeah, it's a good question. I mean, maybe we can save a little time at the end, and you can tell me why you think that is, because I think certainly on I think that there's an age differential too, that the gender balance in global health skews female the younger the cohort is, because people my age in global health, there certainly are women in it, but there are more men than people in their 30s or in their 20s. So at least that's based on my observation. I saw that when I was at the Global Health Council too. But that I digress, because the question that Maeve asked me is, how did I get into this? Well, I'd ask you to guess what my undergraduate major was, but some of you may have looked me up on the internet, so there won't be a lot of suspense around that. But I started off, actually, before I decided to study history of science, which is the degree that I got when I was an undergraduate. I wanted to be a chemist, so I was interested in science. My father had been a chemist, so I grew up around laboratories and was interested in science. My mother was a math teacher, so it was natural to gravitate toward the sciences. But so I went to college, and I discovered that there were 2 reasons why I went into history. One was that I was terrible in the laboratory. So I had an experience. I'm sure some of you have taken organic chemistry or will take organic chemistry. Well, I had an experience in those days. I'm old enough that it was before the days when you had cell phones and calculators. So, to do a quick calculation, you had to take out a slide rule. Some of you may know what a slide rule is, and actually do this calculation manually. And so when I did, I was trying to figure out how much of a reagent to put into the reaction mixture. And so I quickly did this calculation on my slide rule, measured out the stuff, and then put it into the mixture. And the moment it hit the mixture, it was 100 times too much. That's the point of the story. I had miscalculated. And all of a sudden, I heard this whoosh, and the stuff went up the reaction column, came down the sides, hit the flame, and sort of blew into this remarkable ball of fire, which the TA then put out. But then I just thought to myself, maybe this is God's way of telling me that I don't want to be an experimental scientist. But I was always interested in the theory, and also I happen to be relatively good at expressing myself in writing. Most in my day, this is back in the late 60s and 70s, there tended to be a dichotomy between people who are interested in the sciences and people who are interested in the humanities. And I don't know if that's still as sharp a division as it was, but I was actually interested in both, and I was, pretty good at both. So anyhow, I was lucky enough that Princeton, where I went to college, had a history of science program. It was one of the best in the world at that time. And so as I was still interested in the sciences, but I gravitated into history and got my degree in history of science, and eventually got a PhD in history of science, and then went to be a professor in history of science. So the beginning of my career was oriented toward the life of the mind and the academic world. And then after I had been teaching for a while, I had an opportunity to go back to the University of Pennsylvania, where I got my PhD and helped to run a research center that worked on the history of chemistry and chemical technology. So that gave me an opportunity to get more engaged with the chemical industry at that time, and some of the pharmaceutical companies as well. And then from that, I ended up, I had an opportunity to go to AT&T, where I worked for a little while, and then I had an opportunity to go to Merck, where I actually still used my history training, because I was hired to set up an archive and do a centennial history for Merck and Company in 1989. But one of the things that's interesting about working at a big multinational like Merck is there are literally thousands of jobs that you can move into, because it's not, as if, if you go to a university to become a professor, that's what you do, and it's very rare that people change fields, and people will come to a university and stay for 50 years teaching the same courses and doing research on the same thing. But in a big multinational like Merck, by the time I had finished the centennial history, which was the job I was hired for, my bosses had already identified some other opportunities for me to move into. And a couple of years later, I moved into a job as Director of Science and Technology Policy for the US. And that got me involved in coming to NIH and the FDA. And it was a time when by then it was the early 90s, and there was some early research on HIV and AIDS that I had some connection with, because at the time we were engaging with HIV activists to help provide information about the new treatments that were being developed. And eventually in 1996, the first combination antiretroviral treatments were approved by the FDA. So I'd become involved in that as part of this role of doing science and technology policy. And that's ultimately what got me into global health after that. So, now it's been close to 30 years that I've been working in the field in one way or another. But one of the interesting things about the development of my career is I've never taken an academic course in global health. All right, so that might strike some of you as odd, in that now there are hundreds of programs in the U.S. and it's one of the most popular majors on many campuses. But everything I know about it has been through on-the-job training. Having started by working intensely on HIV/AIDS in the mid-90s and on until I left Merck I retired from Merck in 2008. But then I failed retirement the first time by going to the Global Health Council, and then I failed retirement again by going to Rabin Martin in 2011. But it was, what was interesting in the last 15 years that I was at Merck. I was there for almost 20 years. But I had the opportunity to spend most of my time working around the world with external audiences. So AIDS activists for a number of years with the WHO and UNAIDS, with UNICEF and other multilateral organizations, and then at the country level to work with implementing organizations on the NGO side, and with indigenous hospitals and clinics and companies in other areas who are also implementing HIV policies. And then I got to work with the Global Business Coalition on HIV/AIDS, which is now GBC Health. And so I ended up spending a large part of that time as kind of an external ambassador for Merck's global health policy, and that was the role that I spent a lot of time on. Although my formal role by that time, I'd become the head of external affairs, which was largely health policy and communications and media relations and alliance development and stakeholder engagement and a bunch of other things that I was responsible for in a territory that included Europe, Middle East, Africa, Latin America, and Canada. So, that's another aspect of working for a large multinational. You end up working on, a vast territory. And of course, I had lots of help in doing that. There were, my team was about, by that time was about 36 people, but we worked with about 150 people throughout that region. So which is another aspect of working in large multinationals. First of all, there are plenty of opportunities. So, people end up having very rich and varied careers by staying with the same company, but moving around the world into different functions over the course of a career. And also, everything is done in teams. That your task is to learn how to work with a broad team that has all kinds of skills, because you can accomplish much more together than you can alone. That's one thing that's different than the life of a professor, because most professors just spend endless amounts of time alone at their desk, writing things and thinking. It's different in a medical school or in a business school, because that takes on the nature of the kind of professional lives that people who are trained there end up having. But that was one thing I learned very early on when I went into the private sector, was that you learn to participate in teams, you learn to take advantage of the skills that your colleagues have, and you also there's a division of labor that enables you to focus on the things that you have to do, and that was very different than my experience in the academic world. So in any case, as I said, I retired in 2008 after doing a lot of work on HIV/AIDS, and I was involved in the first big collaboration between UN agencies and the private sector to ensure that people in Africa would get access to HIV drugs at prices that were more affordable than they were in the North and the West at that time. And then when I went to the Global Health Council, I continued to work on building the kinds of partnerships that I had learned to do when I was at Merck. And GHC then was now it's a little. Just finish two final thoughts, then we'll move on to the next one.
Can you define GHC
Oh,
for
sure.
folks?
It's the Global Health Council, which still exists. Lois Pace is the executive director. It's based here in Washington, but it's an organization that focuses on advocacy for global health issues for people living on less than $2 a day. So it really focuses largely on lower and middle income countries. And the key challenges that are on the agenda, whether it's maternal mortality or non-communicable disease or HIV/AIDS and other infectious diseases, and they're based in Washington. When I was CEO of the Global Health Council, there were about 500 or 550 organizations in over 100 countries, and so something like 5,000 individual members. They've gone through a transformation since, where I don't think they have as many international organizations who are members, but they still have a focus on advocacy for global health issues, and so they do a lot of work on Capitol Hill and and working with other NGOs in town to really advocate for more U.S. investment in those issues. And it's a good organization, and I think you'll find in December they always do a big meeting on the state of global health. That's something you might be interested in if you haven't gone. And I think they still have membership's relatively inexpensive, and it gives you access to a whole network of people and information around global health. So all I was going to say is that when I then went from basically doing what I'd been doing in terms of creating partnerships and working on these issues to bring the public and private sectors together. When I was at the Global Health Council, I was still working on the same sets of issues, but from the perspective of being one of the largest and most effective advocacy organizations from civil society working on global health. So that was an interesting change of perspective. Then I went, in 2011, I joined Rabin Martin, where we're a consulting firm that focuses on strategy, but we focus entirely on global health issues. So we've, as I said, we're in New York and London, and we work on, probably half the people who work at Rabin Martin have MPH degrees, so there's a lot of public health expertise. And then our client base is largely large healthcare companies, and we work with the Gates Foundation and the Rockefeller Foundation and other foundations. And a lot of our work is devoted to creating partnerships to bring our clients together with people on the ground in Africa and India in particular, to really help improve population health in dramatic ways. So, a big program that we work on is Merck for Mothers, which is a program that Merck & Company, the company I used to work with, set up in 2011 to eliminate preventable maternal mortality around the world. And in the past 8.5 years, they've helped more than 12 million women, and have done a lot of work both outside the U.S. but also in the U.S. in inner cities, for instance, to address the disparity between pregnancy outcomes for women of color and Caucasian women, because I think the number is, my colleagues always correct me because I never get the facts completely straight, but I think it's true that there's something like a six-fold difference in the likelihood that a young woman of color in certain U.S. cities will die in pregnancy, or die in childbirth, I should say, than it is for Caucasian women of the same age. So that's one of the things that Merck's been working on, and they've had some real success in helping to iron out some of those inequalities. So that's sort of a meandering account in a big nutshell of how I ended up going from where I was, intending to become an academic chemist, to ending up working in global health.
I'm glad you didn't become an academic chemist because we need you in the field. There were sort of two themes that I was thinking of as you were sort of telling your story. One is just the theme of advocacy, where we've had other people come and sort of talk about how they've pushed forward issues of importance to them. But for you, it was sort of working through partnership. Seems that this public-private partnerships and the importance of bringing people together in order to achieve those goals. And that's really, in some ways, a skill that you've honed throughout the years. So can you talk a little bit more about, because I think that idea of public-private partnership now is, there's public-private partnership part of the Department of State that didn't exist before. So you sort of created that field as well, or one of the creators of the field through your career.
Well, it's certainly true that a lot of the work I did was based on trying to create certain partnerships. The idea behind it is just that, no matter, so I worked for Merck, one of the largest pharmaceutical companies in the world, has $1 gazillion in assets and, something like $40+ billion in sales. They have an R&D budget that's measured in the billions. But even that company is only a small fraction. For instance, if you look at R&D, they only have a small fraction of the total investment in R&D around the world. So if you're at Merck and you want to accomplish something useful in the world, you have to, if you want to work on your own, you have to make a bet that you're smarter and luckier than everybody else working in that area. And that's something I learned from the scientists when I was there, and when I did this work on science policy. I mean, Merck at one point in the early 90s created something called the Merck Gene Index, which was, at an early stage of the development of genomics, which now has progressed way beyond that. But at the time, they decided that they were going to create a public database of what were called express sequence tags, which were short lengths of DNA, and if you catalog those, you could begin to correlate them with interesting structures that could be used in drug development. You could, use them as probes to deal with certain druggable targets, and then that could lead to potential new therapies. And what Merck decided to do was invest in a project with Washington University to just generate these express sequence tags, hundreds of thousands of them, and then put them into the public databases in what's now a database of ESTs and other genomic data that's kept by the National Library of Medicine. But and people thought that was odd because most companies would generate that information and keep it closely held and try to use it to compete with others in the field. But the guys who were running this, the geneticists and bioinformatics guys who were creating this database together with Robert Waterston and his team at Washington University, the comment that I made about you had to be smarter and luckier than everybody else is something that they told me, because that's why they made this investment, because it was a way of leveraging the 95% of the other R&D laboratories around the world to work on issues that they were also working on. And then, what they realized is that if somebody came up with a bright idea that could lead to a new drug, there's a long path between getting a basic science breakthrough and having a product that makes it through FDA approval or EMA approval, European Medicines Agency approval, to actually be in a position where you can now introduce it to the marketplace and get it to patients who can use it. And what they realized is that if they have everybody in the world who's interested in basic science working on those problems, because it's a probabilistic process, the likelihood that somebody would get a breakthrough was higher, and then Merck could work with them to do the development and actually bring it to market. And that's basically how the entire uh, relationship between the biotech industry and the large pharmaceutical industry has developed over the past 30 or 40 years, because people have made an analogy between the way that biotech operates in relationship to pharma and the way that producers create blockbuster movies. In that they, most of the time when you go see, I mean, what's a new movie? 1917, let's say, about World War I. That movie is made not by a team that's all owned by one studio, right? They don't own the director, the actors, the producers, the people who run the cameras. They don't own the cameras. They don't own the prop people. They don't own the catering service that provides catering for the crew. They don't own the distribution network. They don't own Netflix, and they don't own all the ways that films get to you now. But what they do is just bring that together. It's sort of they bring together the resources that are needed to create a blockbuster movie. And that's the same way that large pharma companies have started to act toward the biotech industry, because often, again, there are hundreds of biotech companies. Let's say you're trying to come up with a new medicine for asthma. There are hundreds of companies out there trying different targets to see if they can come up with a new asthma medicine. And it makes more sense for a large pharma company to simply do a deal with a company that looks like it has an interesting prospect for a product, and then they can use the assets they have in place for a development engine to actually do the further research and the clinical trials that will make that be able to pass the hurdles at a regulatory agency, that medicine is safe and effective and can be introduced in the marketplace. So anyhow, it's that was coming back to partnerships, public-private partnerships in global health. It's the same concept that if Merck was interested in figuring out a way to get differentially priced AIDS medicines to people who needed them in Africa, we could try to do everything along the step the way ourselves, but it was much more efficient to find people who actually had access to patients, who ran clinics in developing countries, who were able to distribute the medicines in different ways. And so, what you end up doing is bringing together a group of partners who have complementary skills and expertise that enable you to do more together than any single partner can do alone. So that was sort of the philosophy behind the kind of partnerships that I worked on. And and we, as I mentioned one that was, is probably one of the best known of the ones I worked on, which was the Accelerating Access Initiative that was begun in 2000, which was a partnership of UNAIDS, WHO, UNICEF, UNFPA, and the World Bank, and 5 pharmaceutical companies that had new antiretrovirals. And together we negotiated an arrangement where the companies made their medicines available at significant discounts, and all the UN agencies helped work with the countries to make sure that they would implement plans to provide antiretroviral therapy to the people living with HIV in their countries. And it began with Uganda and Rwanda. Those were the first 2 countries, and then Senegal decided that they were going to treat. And in retrospect, I mean, if you look at a number of the stories that have been written about those days, one usually the form of argument you'll find is that AIDS activists and patients brought the pharmaceutical industry to their knees over patent protection, and the industry, for defensive reasons, had to eventually license its products and lower its prices. But the reality is that the first time that patients in Africa had improved access to antiretrovirals was through this partnership between 5 UN agencies and 5 companies, which realized that they needed, you couldn't, it was great that when you looked at the introduction of antiretrovirals in 1996 in the North, in the global North, death rates plummeted. There's a famous paper by Pantaleo that looked at this in the US, and what you have are, AIDS, the number of AIDS deaths climbs through the 80s and into the 90s, and then all of a sudden the graph, in 1 year just drops off a cliff because antiretrovirals became available. So, everybody in the industry realized that the same thing would happen in Africa or other parts of the lower and middle income countries. So the challenge was how to get those medicines to people who needed them. But at the same time, there were all kinds of challenges with, with health system readiness, and whether you had the right kind of system in place to diagnose and treat and keep people on therapy. But I remember just to stay with this story for a while, because it's a very complex and story that unfolded over about 15 years. But one of the things I used to do was talk to reporters about what Merck was trying to do in those days. And in those days, Mike Waldholtz was the leading healthcare reporter for the Wall Street Journal. And I remember in 1998, he was having a conversation with me in Geneva at one of the global AIDS conferences. And he just kept hammering me, because this was 2 years before Merck decided to lower the prices of its antiretrovirals. And so, I'm actually on record, if you look it up on the internet, of telling him in 1998 that even if we gave our products away, the health systems in Africa weren't ready, and therefore it would be difficult to ensure that these medicines were used effectively. And, it wasn't as bad as when James Natsios, who was the head of USAID at the time, said that you couldn't use antiretrovirals in Africa because Africans can't tell time, and you had to take medicines at certain hours of the day. So I wasn't quite that egregious. But what's interesting is when he interviewed me 2 years later, and you can look this up as well, I'd completely changed my tune, because by then we realized that we could get the medicines, we could provide them at lower prices, and the sky wouldn't fall in. And we could work in partnership with people at the country level and with international agencies and international NGOs to make sure that the infrastructure was there to make sure that medicines got to people effectively and they would stay on therapy once they started. And that happened all around the same time. Within a couple of years, the Bush administration started the PEPFAR program, which I'm sure Mark Dybul talked about when. That was last semester. Sorry, but Mark's a professor now at Georgetown, but he was involved in creating the PEPFAR program, which has now helped tens of millions of people get access to therapy. But this was all before that happened, and it was really the first major initiative that helped more. By the end of the first few years, almost 1 million Africans had gotten access as a result of this program. And but it took, from the outside, just to come back to what I said about activists, obviously that helped with public opinion, and it helped move the interests of big donor agencies, and it helped make it possible for the U.S. government to think when George W. Bush decided to set up PEPFAR that it made sense to do this. But the other thing that Mark and others who were involved will tell you is they realized it was possible because of the efforts of things like the Accelerating Access Initiative a few years earlier, and a program that Merck got involved in Botswana, where we worked with the government, the Gates Foundation, and Merck to help Botswana completely transform its approach to the AIDS epidemic. And they became the first country in Africa to actually achieve universal coverage for AIDS treatment for their patients. And so it required those kinds of collaborations to really move the needle on these things. And that's what people who haven't worked in the industry don't realize, is that people who decide to spend their career as a researcher in a pharmaceutical company are just as committed to finding the solutions as people in the academic world, or people who work for say ACT UP New York, or the Treatment Action Group, which has been really active on treatment information over the last 20 or 30 years. They just work in a different context, and they have different constraints on their work, but at the same time, they get up every day hoping they're going to find a solution, and they don't want to find a solution to a problem like HIV/AIDS and then not be able to get it to people who are going to need it when there are something like 40 million people around the world who are infected. So the challenge is to find ways to bridge the gap between a company that obviously is a profit-making institution and has to continue to have a viable business model, and the tens of millions of people who can benefit from that, who don't necessarily have the resources. But they're, the other thing, and if some of you read that little article of mine on global disruptors, it's not that there isn't enough money in the world to solve these problems. There's a huge amount of money in the world. It's just misallocated. So the trick is figuring out ways to allocate it in different ways to actually achieve different goals. And that's, in a way, that's what I spent most of my career doing, either when I worked for a company like Merck, where I was able to affect this directly, or when I was at the Global Health Council, when I was advocating for those kinds of changes, or now as I work with clients who have the kind of resources that actually Merck is one of our clients, and we work for a number of other companies like that, where we can persuade them that if they work in this way, they can actually try different models that will be sustainable and will have a much broader impact. So you'll improve population health, at the same time that you're able to bring these new innovations to many more people. So that's what's cool about what I do now, because we can actually, if we persuade clients to try something differently, it can actually end up helping millions of people. And it's just this little group of us in New York and London who are trying to make those things happen.
Well, I like it, imagine you as the little group, but very powerful. One of the things that you said is the health system readiness, and just one of the things that we've talked about, and people in preparing for this talked about your work on universal health coverage. And if we're thinking about how to actually make sure that the medicines that have been created by the scientists actually get to people, we need those strong health systems, and they benefit sort of everyone. So can you talk a little bit about, again, another pivot in your career is really, as the world and the SDGs focus on UHC, so goes Rabin Martin.
Yeah, no, well, we did spend a fair amount of time on non-communicable disease, because that was, back in around the beginning of the last decade. That was really the focus of a lot of work that George Lane really got started when he was head of PAHO, and that continues to be a challenge, obviously, because more people die of chronic disease around the world than of infectious diseases. The last time I looked, it's like 70% of the deaths every year are from NCDs. Largely the big four of them: asthma and other respiratory diseases, diabetes, cardiovascular disease, and cancers. And there are huge gaps in capacity of health systems to deal with that. Everything from, are the right preventive programs in place? Are there the right diagnostics? Are there primary healthcare systems that can actually, see whether people have some of these conditions, then refer them for specialized treatment? Are the treatments available? Do people actually stay on the treatments because you have to take them every day for the rest of your life? And as a result, can you actually get the outcomes that you would predict in a population that takes the treatments systematically and follows all of their doctor's instructions, and things that just don't happen in the real world, which is why there are so many problems. So and that was in the context of the Millennium Development Goals initially, which were introduced in 2000, and then the switch to the SDGs in 2015. And in both the MDGs and the SDGs, one of the things that people tend not to focus on, like the Millennium Development Goals had a specific goal for HIV/AIDS, had a specific goal for under 5 child mortality, had a specific goal for maternal mortality. And then the SDGs were much broader and included not just those specific health goals, but also environmental goals and poverty reduction and education and women's rights. But what people didn't notice as much is that the last goal, Goal 8 in the MDGs and Goal 17 in the SDGs, was about partnerships, because the conviction was, and if you read the preamble and all the rest of it, the conviction was that health ministries alone aren't going to be able to achieve these goals unless they have sort of both an all of government approach and an all of society approach. One of the reasons is, and this comes out more in the SDGs than it did in the MDGs, is that some large percentage of health outcomes really depends on things that have nothing to do with the health system. And that's something that we've come to see much more in the last 10 years. There was a major report in 2008 that was led by Sir Michael Marmot on, it was called the WHO Commission on Social Determinants of Health, and that took a systematic look at those issues. But if you just think for a minute about the intersection of an aging society, so I think the only natural resource that's clearly growing is the number of people over the age of 65 around the world. So, and that's a different conversation, but this relates to NCDs and social determinants. And then when you think about the incidence of chronic diseases like diabetes and heart disease and asthma and mental health conditions and cancers, more and more people over the age of 65 are going to be affected by those conditions. And then when you think about social determinants, so let's say you're over the age of 65 and you have a number of these chronic conditions, and that's actually a growing problem. If you look at Medicare in the U.S., it costs something like, if somebody has one chronic condition, say they have diabetes, it costs a certain amount of money in Medicare reimbursements to keep them on therapy and healthy. But if they have 3 or 4 chronic conditions, which is more and more common, it's called, well, very imaginatively, multiple chronic conditions, or MCCs, the Medicare pays more than 12 times as much on average in annual costs for somebody who has a number of chronic conditions than just one. And part of that also has to do with the social determinants where, let's say they live in a high-rise apartment, and their doctor is in a clinic that's miles away and they have to take public transportation to get there. Some people who have, let's say they have heart failure or emphysema from smoking for decades, they don't want to walk up and down their high-rise apartment to get to the bus stop to take, to wait hours to take the bus to the clinic. And so most of the time, they'll just say, well, I'm not going to go today. I just don't feel up to it. And that just exacerbates their condition. So and then it gets to the point where it spirals downward and they can't leave their apartment. And then somebody has to send an ambulance to get them and bring them to the clinic. And all of that adds money. And so when you multiply that times tens of millions of elderly people, living alone in apartments, times the amount of money it takes to deal with chronic conditions or to send ambulances to get them, it all adds up. And so where they live, what they eat, whether they have friends and a social life, because interdependence is, there's a really strong correlation between the degree of interdependence of elderly people who are living with chronic conditions and what their health outcomes are. So the more they're isolated, the more likely they are to be ill. So anyhow, the point is that to deal with these things requires partnerships, and that was the point that I was making. And so that's why it's in the MDGs and the SDGs, and that's why to deal with just almost any of the major health threats we take is going to require a wide range of multi-sectoral partnerships, and that's really what we try to work on in specific instances with our clients. And I think that it's also part of where the global health community stands right now. And one last thing I'll say about this is that Tedros, who's the relatively new head of the WHO, understands this well. And one of the comments he keeps making when you follow his speeches is that health is a political choice. So we tend to think that, or there is a general feeling that health is about what health ministers do, and it's about what doctors do and nurses do on behalf of people who are living with various conditions. But actually, he's right, because in every country, just about every country, the U.S. is slightly anomalous in this way, but just about every country manages its health system through tax dollars and tax resources. And so the decision on how much to allocate out of the general budget is a political decision. The decision on how to allocate what's in the health budget, whether it's going to be in surgery, building new hospitals, dealing with primary care, paying for drugs, paying for medical devices, paying for mental health, all of those are political decisions. They have technical elements, but ultimately they're political decisions. And health ministers end up spending most of their time negotiating with finance ministers on what envelope of resources they're going to get. And again, those are all political. In other speeches, Tedros has said health is too important to leave to the health ministers, for all those reasons. And of course, politicians who make the decisions about resource allocation are also paying careful attention to what voters want, because that's how they maintain job security. So if people start agitating for different decisions about health, then you can actually move the needle. But to do that, you need coalitions, you need partnerships, you need people to start agreeing on common ground on how to improve health outcomes so that we can keep population health improving. And it either becomes, you either get together the right coalition of partners to work on things like that, or you're constantly fighting for what little you can get from a declining amount of money that goes into healthcare.
I had a couple of things, but the idea, the political nature of global health is also something that's come up in this class a few times. And so just turning to what you were doing on Capitol Hill today,
sure.
and one of the more political global health crises that is occurring currently is the coronavirus. And that is not just about data, and it's not just about global health security, but it's about the politicians and how people are acting. So can you just sort of re-describe, as we talked before, about what you were doing on the Hill today and what
Sure.
the discussion is going on?
Yeah, no, I was, this afternoon there was a launch of a new report by the Center for Strategic and International Studies, a think tank downtown. And you've probably come across it from time to time in your studies. But they created a Commission on America's Health Security about 2 years ago, and today they launched the report after 2 years of work. And so, looking at global health security broadly, the idea is just how can we be better prepared to deal with health emergencies and emerging diseases, and coronavirus is a perfect example. I mean, the timing couldn't have been better given that that epidemic is just developing now, but it also has to do with things like Ebola, or before that, the SARS epidemic, or the H1N1 epidemic before that. But the problem is, and the theme of this report is that we have to get away from the cycle of crisis and complacency that has affected most global health emergencies and global health security. The other aspect of global health security is not only preparedness for new epidemics, either of existing agents like the seasonal flu. That's something we have to be prepared for, because vaccines have to be reformulated given what the genetic complexion of the flu virus is every year. But also, it involves things like bioterrorism, or the interaction of, for instance, in parts of the Middle East, hospitals are being bombed. Health workers who are there to try to eliminate polio are being shot and killed. So there's just this whole complex mix of really bad and scary things around global health emergencies and pandemics that require attention. And it's also, I mean, the old cliche that an ounce of prevention is worth a pound of cure applies, because if you plan ahead of time for what to do if a new virus emerges, like coronavirus, then it costs less. The interventions are more effective. You can manage the fear and concerns that sort of ripple through society. Often, I first saw this back in the 80s when I was living in Philadelphia in graduate school, and 3 Mile Island almost blew up, right? And it was interesting. This is a variant on the same kinds of conversations that I'm sure are happening all over the country with respect to coronavirus. But I was at a dinner party one night with some friends, and one of them was a physicist, and the other was a musician. There's a young woman friend of ours who was a musician, and she was like in tears because she was afraid that her life was in danger because of what happened at 3 Mile Island. Even, we lived probably 100 miles away in Philadelphia, and this was out in central Pennsylvania. And my physicist friend tried to explain to her, rationally why. Well, look, he sort of wrote out the equations and showed that, by the time any radionuclides, had dispersed through the atmosphere over 100 years, 100 miles, the dosage that you would be exposed to is less than, you would see if you went to the dentist and got one tooth x-rayed. It would be nothing to care about. But she couldn't be persuaded that she wasn't in danger that moment sitting in Philadelphia. And with coronavirus, we're seeing the same sorts of things. The stock market went down dramatically on Friday just on the fear that something would happen. There have only been a handful of cases in the U.S., but people are anxious. And most of the cases are people who were in Wuhan and flew back. And I just read, like, of the first 5 cases, 4 had been in Wuhan, and 1 was married to one of the 4 who came back from Wuhan. So, so we don't actually have a full-blown epidemic in the U.S. But think back to Ebola in 2014, 2015. There was one guy who came back from Liberia, I think it was, who rocked up in Austin or Dallas, and the whole country went crazy, because of this one person who had been exposed. But I'm not trying to downplay the seriousness of this, or try to deprecate the emotion that many people have in response. But the whole point of global health security is that you can prepare for these things. There need to be mechanisms for communicating, and the CDC should have regular bulletins out to people, and they should canvass what people are worried about and make sure that there are responses that are calibrated to the level of anxiety that people have that aren't just, it's not just Tony Fauci and some technical explanation on TV, but there are actually people who they trust who can tell them, well, here's how it works, and here's what makes you at risk, and because most of the people who have this disease are halfway around the world, you're not going to get it randomly. But on the other hand, don't go to live animal markets where you could be at risk, much greater risk of catching this new coronavirus. But anyhow, today's meeting was all we were talking about those issues. But what's interesting about come back to this point about how health is a political choice. What's interesting if you've been following this is that the Chinese knew that there was something going on in Wuhan in October or November. And here it is February, and we're only really now hearing about what actions they've taken, and and they've actually made this dramatic decision to quarantine about 57 million people. And after a third of the population of Wuhan had already left town, so it's a classic case of the horse being out before the barn door is closed. And also, we know from 100 years of pandemic control that quarantine is ineffective. Right? So, but what was interesting is one of the reasons there was this gap between when people knew something was going on and when the Chinese government began to take action in a public way is because these decisions went all the way up to Xi Jinping, and because the Chinese Communist Party controls they have sort of political control over everything that the health ministry and the local ministries do. The doctors who knew something was up were prohibited from sharing that information with the public, much less publicizing it more broadly, until the politicians had decided that it was okay to share the information. So that kind of secrecy and lack of transparency is a big reason why the SARS epidemic had the impact that it had, and now again with the coronavirus epidemic, that's one of the reasons there are more than 15,000 infections already, and why they feel that they have to now quarantine this large population. But what's interesting, the other thing that was coming up now, flip it around. So there were political considerations in China on how they were going to address this, and even now that they've decided to go public with it, just think about what's been happening between the U.S. and China recently. So when SARS came out, the U.S. and China were actually getting along much better, and so there was more cooperation on a technical and on a material level between the U.S. and China to help limit the spread of SARS. Now, I think it's fair to say that the U.S. and China aren't getting along that well. I mean, think of the tariff war, think of a number of other things like fights over technology transfer and all the other things that the Trump administration has been doing to harass China. So, just it's an open question, but do you think that they're that well disposed to cooperating now with the U.S. in addressing this epidemic, particularly since the U.S. and the British airlines and others have now said they're going to stop flying to China? So that has a dramatic impact on the Chinese economy, and it will, because of global supply chains. And so, that's a diplomatic mess that's going to continue to have an effect on the global economy. And then come back to the U.S. The U.S. now has decided through Secretary Azar that they're going to quarantine people coming into the country, and they're going to put all these restrictions in. And we know that, as I said before, and this is what came up today in this discussion on Capitol Hill, which included senators and some of the members of the House of Representatives and a whole range of experts from different aspects of thinking about global health security. They found out that, they know that from decades of public health practice that eventually a quarantine is not going to work because people are ingenious about getting around a quarantine. So, there will ultimately be more infections in the U.S. And then politics will come into play again because that will be weaponized given our current political climate of, complete inability to disagree on what time of day it is, much less anything substantive. So what will happen inevitably is that there will be people on one side claiming that the government failed to contain the epidemic, as if it were a failure of government policy, when it's simply a fact that viruses are wily adversaries, and the coronavirus really doesn't care if you have people quarantined because any chink in that armor will be exploited by the virus, just because that's what viruses do. So it's just a completely, it's a hugely complicated set of issues. But the technical issues about how does the coronavirus actually infect people, how lethal is it, what's the percentage if you're infected, you'll die, and then what's the probability that you'll transmit it to others? Those are the two critical factors in any kind of epidemic. And as scientists are trying to figure that out, this whole thing will play out in the public sphere in ways that have much more to do with politics and with public perceptions and the level of knowledge than anything else. I mean, one of the things that came up at this meeting today was there's a person who works on national security who said that already there have been rumors around that this was being done to really to cripple the Chinese economy, so the U.S. would get an advantage in the global competition. But what they've already learned is that the people who've been spreading those rumors on the internet through social media are the same people who interfered in the 2016 election, the Russians, not the Ukrainians, and and this is tied into people who are known adversaries of the U.S. in terms of national security, because what they're trying to do is weaken institutions through cyber methods. And if they can spread craziness about the coronavirus and get people all worked up and fearful, then it again weakens trust in.
Probably doesn't help that Wilbur Ross actually said this is actually good for the U.S. economy.
Yeah. Well, no, that doesn't help either. But anyhow, that's what we were discussing today, and it comes back to, I mean, that discussion shows that Tedros is onto something when he says health is a political choice, because the way that all of these issues will, one other thing that was noticed is when Tedros declared coronavirus a national health emergency, he went out of his way to praise China for what they'd been doing to stop it. But of course, that just aggravates the U.S., the State Department and administration, because they're in the midst of this big trade war with China, and that didn't help Tedros's case. So, and the U.S. provides most of the WHO budget, or the largest share of the WHO budget of any of the member states. So that wasn't a particularly astute comment by Tedros in that statement. But though those are part of, or those angles are part of how to make sense of what's happening in global health around the world. So.
Thank you so much, Jeff. And I think we're just reminding us all what you said, which is biomedically, we actually know what to do with a virus. And it's the political and the human and, and how do we address those which are complicated, and everyone's, there is sort of an interest. There is definitely an interest in partnership, but what does that mean? I want to make sure that we have time for our students to ask questions for you. So I'm going to turn it to. Do you want to start? Sure. And can you, before I ask a question, will you just remind or say your name and your program, please?
Hi, I'm Joey. I'm a sophomore studying international economics at the School of Foreign Service. And my question is that the private sector can be good for like investing and funding different programs, and then research, of course. But there's a lot of negative consequences, such as like inflated pharmaceutical prices. So what are the cautions of the private sector getting involved in the healthcare system, and how can these issues be mitigated?
Later tonight, when the president does his State of the Union address, everybody's predicting that he's going to hammer the pharmaceutical industry just because it's an easy political target. But on the other hand, you could ask the question, well, what has his administration actually done about pharmaceutical prices? And the answer is not much. So, and that's a perennial challenge. But look at this question more broadly, because, and if you looked at some of the articles that Maeve was good enough to send around of some of the things I've written, a lot of folks think that that public health should be just that, public, and the private sector should have nothing to do with it. And I think even if you believe that, there's a problem with that conviction, because if you just think about how health commodities get to the people who need them, it's through the private sector and the marketplace. So you can't avoid private sector engagement in implementation of either, doctors or corporations, right? So they're in the private sector. You think Georgetown probably has $1 billion hospital, which is a privately owned hospital. So just wherever you go in the U.S., health insurers are all private corporations. Most of the $1 trillion that the U.S. Trillion plus that the U.S. spends on healthcare every year, a lot of it is funded by the government, whether it's Medicaid or Medicare, but it's delivered through the private sector, and so that leads to all kinds of curious and interesting anomalies. For instance, we spend more money on administrative costs in the U.S. healthcare system than we spend on cancer care. So those are some of the pathologies of having a system that's a mix of public and private, but they're not. Those aren't necessarily. They don't necessarily have to be. Those pathologies don't necessarily have to occur because you can redesign the system, and that's what the debates over the at first when when I was a young public policy guy at Merck, or a younger public policy guy at Merck, we spent hours and hours poring over the Clinton Health Care Act to see if there were ways that we could figure out how to use the provisions that they were making that would make it possible for us to do more to actually improve health in a way that was consistent with our business. Now there's been this debate for years about Obamacare and whether it should be repealed or replaced or changed or whatever. But that's all based on these basic tensions about, people demand health care reasonably enough, but how are you going to provide it efficiently and effectively given the resources that are available? The other thing that, if you look at healthcare outside the U.S., again, many countries, for instance, people in the UK will tell you that they have complete faith in the National Healthcare Service, which is government run and government funded. But most of them, at least if they're middle class or in the professional classes, also have private top-up insurance because they don't want to go to their local clinic because it's mandated by the NHS, or they don't want to wait for a specialist and wait for an operation, so they just opt out and use private resources. If the UK didn't have that kind of private healthcare system on top of the NHS, it would fall. The NHS would fall apart. There would just be too much demand for the system, and as it is, they've had challenges with waiting lists and an allocation of resources for decades. In other countries, let's take a look at places like India or a lot of African countries. Again, the assumption is that it's all public sector, it's all run through tax-funded resources. But India provides something like 80% of its care through the private sector, because the government simply doesn't allocate enough resources to treat the health needs of over 1 billion people. And so you have a very complex and robust system of private providers and private hospitals, hospital networks and managed care organizations and doctors groups and everything who actually provide most of the care that India has. So partly, I wanted to just sort of turn your question around a little. It's not, that there are problems and you have to worry about pathologies that the private sector might bring to the healthcare system. Healthcare systems around the world would fall apart unless there was private sector engagement. That's the reality. So the question is, what are the outcomes you want, and how can you redesign the system to make sure you get those outcomes? So, so in the U.S., for instance, let's just stay with that example. There are pharmaceutical companies, for instance, can't promote medicines off-label, and that's part of the whole system that the FDA administers, and that's there to ensure the safety of people who are taking those medicines. So that's one kind of check. So you have regulatory interventions that you can use to make sure that companies don't do things that are against the law or skirting, ethical guidelines. When companies, act in ways that that are anti-competitive, they get huge fines. So there are other kinds of legal remedies and guardrails that are put in place and are in place. But it's not just pharmaceutical companies. I haven't looked at the most recent data, but it's usually the amount of money that that the U.S. health budget that's allocated to pharmaceuticals is less than 15%, and it's actually been going down over the last several years. So despite the fact that you have, for every medicine like Zolgensma, which is a new medicine for spinal muscular atrophy that Novartis sells, which is now the most expensive medicine in history at $2.1 million per treatment, but they argue that it's cost effective. But that's a different. We can go into that in great detail. But for every $2.1 million medicine, you have 100 that cost a couple of pennies a day. So there's a huge distribution. So just to say drug prices are too high is actually a little bit simplistic. But the other point is that if you look at it in the context of all the money that's spent on healthcare in the U.S., and this is true for most developed country economies, the percentage that's spent on drugs is relatively small compared to the amount of money that's spent on doctors and other healthcare professional fees and hospital care. So so the U.S. could actually say, and remember, I said that we spend more on administrative costs in the U.S. than we do on cancer care. And it's a paper by David Cleary and some of his colleagues at Harvard that came out a couple of years ago in the New England Journal that spells it out in great detail. So if you really want to reform the U.S. healthcare system, and you just focus on pharmaceuticals, you still have an enormous problem of inequalities and disparities in access to care that are actually much more complicated for people to solve than just bringing down the price of drugs. I'm not arguing that we shouldn't. I mean, personally, I think that the U.S. Industry has tried for decades to keep from having government control of prices, but they make very robust prices in every other country in the world where prices are administered. So I think the argument that you can't control our prices, there will be no new medicines, is just belied by the facts, which is everywhere else in the world there are price controls and there's still robust pharmaceutical innovation in those countries. So I think inevitably, just given the pressures on our system now, there will be some form of price control. I predict that within the next 10 years, Medicare will negotiate the price of new medicines, which is the hill that the pharmaceutical industry has said that, they're just never going to agree to that. I think it's inevitable that they're going to agree to that, particularly now, when the Clinton healthcare plan came in the early 90s, that was a Democratic plan, and the Republicans were dead set against it. Now you have both Republicans and Democrats arguing that the pharmaceutical industry we have to do something about the pharmaceutical industry. That doesn't bode well for the outcomes that the industry would like to have. But so that's one point I was just trying to make, is that at least when you look at pharmaceuticals, it's a complex situation, but the industry actually, if you think that prices are too high, the other thing that people miss is that there are thousands of different purchasers in the U.S., and the U.S. already has a highly competitive market for pharmaceutical prices, in that most of those purchasers, most of those buyers, all have different prices. And it's worked out so that because the price negotiations are secret, Richard Cave is an economist who you may have come across, who's actually written about this. If each of those purchasers and sellers negotiates a price that both of them are happy with, and doesn't signal what that price is to the rest, to all the other purchasers and sellers, the prices on average are lower than they would be if you actually had the kind of transparency that HHS has been calling for. And because the other thing that we miss about this is that, if you have heart disease, for instance, there are literally hundreds of drugs you can take for hypertension. And so there is actually a perfectly competitive market for hypertension drugs. I mean, I actually have hypertension. That may be more information than you need. But, my main hypertension medicine costs a couple of dollars a month, right? It's not thousands of dollars a month, because there are probably 50 other medicines that my doctor could prescribe for me. Most of them are generic. And actually 90% of U.S. medicines are prescribed generically, and those have very low prices. So it's just a very complicated picture. But I want to just spend 1 minute on other kinds of challenges in the role of the private sector. For instance, there are some who argue that there are companies in the private sector that actually cause chronic disease rather than fight chronic disease. So think of food companies and beverage companies and alcoholic beverage companies. And so, yes, if people drink too much sugared Coke, they're going to have a problem. Could have a problem with diabetes or heart disease or other things. And similarly for other products. And then think of tobacco companies, and there are a range of products that are marketed by companies that actually can have deleterious health implications. But there the solution again is regulation, and it's both self-regulation and government regulation. I mean, if you look at the International Food and Beverage Alliance, which is, a lot of big companies like Coca-Cola and Pepsi and food companies like Mondelez and Nestle and Danone and others, they've actually agreed to a set of requirements that were agreed with the WHO some years ago, and they've taken trillions of ounces of fat, salt, and sugar out of the food that they formulate. So that actually has a positive impact on health outcomes. But it's not. Companies like Pepsi Cola is well known for this. That when Indra Nooyi was CEO of Pepsi, she spent billions of dollars designing new foods that were good for you. In addition to, they still sold, at that time they made Fritos. They sold it off later, but they still sold foods that were fun for you, as she said. But they were also, just because the marketplace required them to, because people stopped buying high fat, high salt, high sugared products. So it really was in their interests as a company to make foods that people wanted to buy that were healthier. So the point I'm just making is that, yes, you can point to, we haven't even talked about climate change and carbon emissions and practices that companies have that are deleterious to the environment. But what's interesting is that the combination of economic self-interest, public pressure, and government regulation actually moves things ultimately in the direction of products that people are willing to buy. And if everybody wakes up one morning and decides, we want to eat kale instead of Big Macs, then the marketplace moves in that direction. So there, and if you just think of like the biggest product, the product that's had the most deleterious effect on more people than anything is tobacco. And so now, just in my lifetime, there's been a tremendous social transformation in people's attitudes towards smoking. When I was a kid, my mother smoked a couple of packs a day. My father smoked cigars. Every adult I knew smoked. And now you walk down the street and you barely run across anybody smoking. This transformation, and it happened quickly too. I used to go to Norway all the time, among other things, when I was working at Merck, and Ireland. I went to Ireland a lot. So, and it was in the space of a couple of months. It used to be if you went to a pub in Ireland and you sat there for an hour, when you came out, you just smelled like an ashtray. Right? It was just inevitable and unavoidable. The same thing was true in Norway. In fact, Norwegians smoked more than any other European country on a per capita basis. And in the space of a couple of months, that completely changed because enough people advocated for changing the laws that you could no longer smoke in pubs, and eventually you could no longer smoke in public places. And so it's possible to change these things because, for one thing, tobacco, I think, and personally, I think it's right that it should be, a product that actually, if you use it properly, will kill you. Doesn't seem to me to be a product that really needs to be available to people. But those kinds of changes will happen as a result of those three factors. And what we've been seeing over the last 10 or 20 years is just an acceleration in the way in which people are more aware of this and are asking companies to change their practices. And because companies, want to have customers who want to buy their products, are going to move in that direction. So it's really, from that point of view, it's relatively easy to get companies to change what they want to do. You just have to make it clear to them either by voting with your feet or getting others to raise their voices that their current practices just aren't going to lead to the kind of outcomes that they would like to have. And you've seen that in industry after industry, I think. So my point is that that companies respond to economic incentives. So you're beginning to see more and more use of those kinds of economic incentives to change their behaviors.
Thank you so much. And I also just that I think you made such a good point about the ease of advocating about high drug prices, which is not that we're not in disagreement about that drug prices too high, but when we look at how complicated the issues are, it's much easier to, the low-hanging fruits are those things that we can define in one sentence. And it is much more complicated than that.
Yeah, and just one final point about that. It's not that drug prices, what I would do is say some drug prices are too high. And so the question is that if there's more public education about the nature of the drugs that they use. So for instance, you can go, if you get prescribed a brand name drug that you have to pay 4 times as much in a copay, and it also costs your insurers a lot more, you can just ask your doctor for a generic version, because most drugs do have a generic version. So that kind of consumer awareness can actually, and you multiply that by 300 million people in the U.S., that will shift the marketplace. And actually, that's largely why we have 90% generic prescribing now, because that's in 1980, I remember this statistic that there was hardly any managed care in the U.S., and now it's virtually all managed care. And a concomitant of that has been managed drug administration too. So now you have these pharmacy benefits managers and this really complex system. It's so rare that like you never just walk into your pharmacy and ask them for a particular product, because there's a whole network of pharmacy and therapeutics formulary committees for your drug company that have negotiations with pharmacy benefits managers, and then they have negotiations with drugstore chains. And all of that leads to why you get the product you get. When your doctor prescribes X, you get something else at the pharmacy. But that's happened over the course of 40 years because of economic forces and economic incentives. So, so it's possible to change these things.
So I'm Paula. I'm a sophomore studying global health in the School of Nursing and Health Studies. And so you mentioned how the current head of the WHO really emphasizes that health is a political choice. And I'm just wondering how you think that this concept has changed in like the past decades, and what has it always been seen as health and politics as Okay, so yeah, so how do you think that, at least in your career, you've seen this concept either be changed? Because I think at least that nowadays it's more so seen as health as a political concept.
Yeah, I think actually this reality has been around for a long time. If you go back to the mid 19th century, Rudolf Virchow was a German physician who created something called a discipline called social medicine, which had to do with the kinds of things I was talking about earlier on social determinants. But he's the first person who's well known to have made this comment about well, for one thing, he said medicines are diseases of society, so that that had to do with his interest in social determinants. But he also made this linkage between health and politics. And that's sort of been a thread through public health ever since the mid 19th century. And then if you fast forward from Virchow to Bismarck in the 1880s, Bismarck was the first politician who put in place universal health coverage, and that he did that for political reasons, because he knew that voters would be interested in keeping his government in place. If he was able to give them, insurance that would, keep them out of the hospital, keep them from going bankrupt if they had a big illness, and so you can actually trace this back. And Jesse Bump, who used to be at Georgetown, and I think he's now at the Harvard School of Public Health, but he's written a really interesting paper about the historical roots of universal health coverage, going back to the Germans and to the French in the 19th century, and and pointed out that actually, although Bismarck put social health insurance in place in the 1880s, it took Germany almost 100 years to get to true universal health coverage. But and if you just think about the way that you can't look at what's happened in the U.S. over the last 10 years with Obamacare and not think that health is political. It's and the reason and all of this has to do with. It's not surprising that it becomes political, because you're talking about $1 trillion industry, and and a large chunk of the entitlements budget of the U.S. government, which translates into taxes, which translates into voter interests and who's doing better for them and stuff. So it's all about power and money, and those issues always lead to political discussions and political decisions. So, and it's true not just in the U.S., but in every other country in the world. I mentioned before, Xi Jinping doesn't want his officials to tell the world that they have this new epidemic until he's sure that he can control it. So they keep a lid on it for political reasons, and it's administered. That control is administered through the Communist Party, which is in control. If you look at think of the debates between Sanders and the other Democratic candidates about Medicare for all, and then you know that in the election in the fall, whoever the candidate is, the Republican opponent is going to talk about it as democratic socialism because they're trying to do something different with healthcare. In every European country, because the system of the healthcare system is run by and paid by the government, the core healthcare system, all of the decisions that they make about whether they're going to reimburse for new medicines, whether you're going to be able to get access to a new hearing aid that's digitally enabled, whether you can get glasses or go to the dentist, all of those decisions are the result of what allocations they make to different aspects of the healthcare system service. And so it's inevitable that these are political decisions. So I think the short answer is, as far back as you can trace, health has been a political choice, as Tedros says. What's interesting is the reason that he's so, he's really an interesting guy because he was actually trained at Hopkins, at the Hopkins School of Public Health. And his first big job in government was health minister. So, some of you may have studied the system of community health workers that he implemented it when he was health minister. So they have something like 36,000 government-paid community health workers in Ethiopia. And it's had a dramatic impact on health outcomes because of the transformation in primary care. But after he was health minister, he became foreign minister. So, you couldn't imagine something more different than being health minister than being foreign minister. But that's what gave him this insight that ultimately, if you want to change these things, and certainly if you want to change them on a global level, you have to bring diplomacy and politics into the conversation, where you really can't get access to, most of the resources that governments have because they're always going to be allocated to other things. So it's just, and also when he became head of the WHO a couple of years ago, normally what the new head of WHO does is go around the world and meet all the health ministers. He started with foreign ministers and finance ministers, not health ministers, because he knew that ultimately his success was going to depend on having political support and having financial support from member states for what WHO wanted to do. So I think it was really astute, but it comes back to health as a political choice.
Hi, thank you. I'm Sadia, and I am a politics. So my question is more about research and developing countries. So since it plays a crucial role in the development of like statistically based studies that in turn shape health that healthcare practitioners pay attention to. In some countries, health research pays more attention to like the indicators defined by international standards rather than local context and like local design of health. And so I was wondering, what do you think the private sector can do to support research initiatives?
Yeah, it's an interesting question. I think that one of the things, and again, my experience has been largely in the pharmaceutical industry, so I'll use that as an example. But the industry actually supports a tremendous amount of research in lower and middle income countries through the clinical trials it conducts around the world. And and actually what they try to do is build capacity in local, in various countries to do that research. So I'll give you two examples. One is countries like Spain for many years used to actually, because remember in European countries, the government decides how much they'll reimburse for medicines. So Spain was actually pretty smart. They had a system, where they would rate the companies on what kind of a contribution are they making to the Spanish healthcare system, the Spanish economy. And then let's say they ranked them on a scale of 1 to 100, and companies that ranked high actually got credit for that contribution, were able to get a higher reimbursement price for their new medicines. So that provided an incentive to fund research in Spain, because that's what it was called, the Plan de Fomento, or the plan for growth. And that was a way that the Spanish government provided incentives for companies to invest in research in Spain. So they would invest in clinical research in various universities. They would invest in basic research. and that all gave them credits for this system that decided how to allocate the drug budget. Other countries like South Africa, companies over decades have made real, substantial investments in helping, major South African universities like the University of Witwatersrand or the University of Cape Town to build clinical capacity to do clinical trials in South Africa. And that's been important because a lot of countries would like their, Japan used to require this, and a number of EU countries did as well as African countries. India is also, well known for this. Before they'll give you approval for a new medicine, they want to know that you've done clinical trials in their populations. So that's another incentive for investing in healthcare infrastructure and research infrastructure in those countries. So, and some companies like, for instance, the company I used to work for, Merck, for 25 years had a fellowship in clinical pharmacology, where they would give that fellowship to someone from South Africa or from Latin American countries. And what's interesting is that, and then that would enable them to do research in clinical pharmacology, which is a discipline that's absolutely critical for drug development. And many of those scholars then became leading professors in South Africa. One became the head of the FDA in Japan, because that, those investments early in their career gave them the opportunity to become part of the international research community, and then, that then led them to these successful and important positions later in their careers. So, those are just a couple of examples, but I think that there are, it's actually, and think about it, it's actually in the company's interest to make those kinds of investments, because then it makes it easier to find laboratories and clinics where they can actually do the research they need to get approvals, or regulatory approvals. And so it works both for the country that's their partner and for the company. So, and that's why you see more and more of that. I think more generally what's interesting is there's more and more of a global economy in, I'm just using that term in the most general sense, of where people make decisions about where to invest in doing research, and also where to train people, and how to ensure that it's actually, if you just think about, if you're in research administration, if you're trying, let's say that you work in a company that's based in Germany, but you're a global company and you want to make sure that you have you maximize your chances for success in developing a new product. You actually want there to be as many countries as possible where you can get people with the requisite skills and experience to do the kind of clinical research you need. So that's really what people have begun to do over the last 20 or 30 years, is make those broadly based investments, so there are more and more countries where you can do that kind of research. And then the folks who've been supported in those countries then become part of a global research community. So you find that, for instance, the NIH has the smallest institute at the NIH is called the Fogarty International Center. And their mission in life is to create research partnerships between lower and middle income countries and U.S. institutions, so that people come and train in the U.S. and go back to their country and train others. And that sets up these kinds of twinning arrangements that actually lead to better research on both sides, because it enriches the U.S. community as well as, whether it's South Africa or Nigeria or another country. And that, and so even though it's the smallest NIH institute, the money they have has had a disproportionate impact on improving the quality of research around the world. So I think, there are lots of examples like that.
Sure. Hi, my name is Victoria. I'm a junior in the SFS studying global business. And I was interested particularly when you were talking about NCDs, and particularly their rise in developing or emerging countries. And I was wondering what private sector initiatives or partnerships you've seen implemented in these countries to effectively combat these diseases, and what are some of the challenges that you're seeing?
Well, I think one, it's a big subject, and I think that, one of the ways the private sector has been engaged in this, just to change direction for a moment, is, when you just think about it, 70% of deaths around the world are caused from chronic conditions, and that's affects people in lower and middle income countries as well as in the global north and highly developed economies. And in fact, something like, if I the statistics are are available on the WHO website, but I think that 70% of deaths, and then of those deaths, something like 80% of them are in lower and middle income countries. So it actually disproportionately affects people in those countries, even though these diseases used to be called lifestyle diseases, and with the implication that they only affected wealthy people around the world. But that simply isn't true. And so so that's one point. But then, if you think about the role that the private sector can play, most people work, and most of us who work spend a lot of time in our workplace. So since, one of the things that the Robert Wood Johnson Foundation says, getting back to social determinants, is most health occurs where people live, learn, work, and play. So if you just think that all of the interventions that are going to help people live healthier lives are going to take place in a clinic or a hospital, you're missing a huge opportunity to help have an impact on people's lives and health outcomes. So one of the ways that the private sector has begun to have an impact on NCDs around the world is through programs that focus on the workplace. So, and they do that in a number of ways. This isn't an NCD example, but one of the things I worked on 20 years ago through the GBC on HIV/AIDS and malaria was to encourage companies to have policies on what to do about HIV, people who are HIV positive, and to make testing available, to make sure people had access to therapy, to make sure that there were education programs available to people in the workplace about how to ensure that you weren't putting yourself at risk through different sexual behaviors. And so there was a huge movement about 20 years ago for large multinational companies to do that, particularly in countries that had generalized epidemics. And the same thing's true for NCDs. So, the company I used to work for, you actually got lower healthcare, you paid lower healthcare premiums if you could demonstrate that you didn't smoke, for instance, because that's what led to most of the healthcare expenses for that company's covered population. And that's a common thing that companies do, is just make it provide incentives to people to have healthier behaviors. And then companies are also doing things like building fitness centers and giving employees the opportunity to get more physical activity. Having a non-smoking workplace. Those are all things that are sort of structural changes that can be made that help nudge people in the direction of healthier behaviors, which leads to an impact on NCDs. Then there are other ways that companies do this. They, in addition to focusing on the workplace, they can work together with others. This gets back to what we were talking about with partnerships on things, everything from training healthcare workers so that, and again, this is in the company's interest. If let's say you're a big company that has operations in Brazil. Brazil's probably a bad example because they have a good primary healthcare system and lots of primary healthcare workers. But let's say that in particular parts of Brazil where the company has an operation, they can help the local government train more healthcare workers. That helps the general population, but it also helps the population of their workers and their workers' families because they have access to better primary care. And then that leads to higher productivity, so it's actually in the company's interest to make those kinds of investments, and there are plenty of examples of that. And then the other thing that they can do is actually just, and this is much more directly related to the kinds of products that they make available, and so this applies to other companies as well as pharmaceutical companies. But one project I worked in with a pharmaceutical company called AstraZeneca a couple of years ago is called Healthy Heart Africa. And to make a long story short, they realized that not many people were using their antihypertensive medicines in Kenya. And it turned out that Kenya has something like 8 million people living with hypertension, but hardly any of them were on treatment. So we worked on a project with AstraZeneca to, number one, one reason that not many people were using their products was that they were 10 times as expensive as other antihypertensive medicines. So we got them to change their entire supply chain so they could lower the price by a factor of 10. So now instead of $1 a day, they were 10 cents a day, and so they were now the same price as other antihypertensives. But then they had to figure out a way to reach the people who didn't know they had hypertension and make sure that they began to get on treatment. So we worked on a big project that, number one, we worked with a number of NGOs that were being supported in Kenya by the PEPFAR program to ensure that the well-run clinics that treated people for HIV and maternal and child health were available to something like 2 million people a day through this network of 2,000 clinics. So that was a much more effective way of reaching a large population at the primary care level than detailing cardiologists, which is what they'd been doing before. And there were so few cardiologists in Kenya that even if every single cardiologist prescribed AstraZeneca products for every time they found somebody with hypertension, it still was only going to reach a few thousand patients, which is exactly what was happening. But by implementing this program of routine blood pressure screening for everybody who came to the clinic in this network of U.S. government-supported clinics, they were actually, over the first few years, able to screen more than 11 million people, and they found more than 1 million who had hypertension who weren't on treatment, and then were able to get them on treatment. So that was a way of, instead of taking a traditional kind of approach to this problem, by taking a public health approach, you could actually have a much greater impact. And it was also sensible for AstraZeneca because they ended up selling more of their products. Even though it was at 1/10 the price, they were selling it to, ultimately to millions of people, millions of patients, not just a few thousand. So it worked out to make sense both for them as a sustainable business and also for the Kenyan government and all these communities in Kenya who were now getting better treatment for hypertension, which was at the time they started this, it was the leading stroke from uncontrolled hypertension was the leading cause of death among adults in Kenya. And so they're actually able to have an impact on a really big public health problem. So that's another way in which the kinds of partnerships we've been talking about actually do have a major public health impact if they're designed in the right way. But that was done through, there were 5 big NGOs that were involved in this, the Kenyan government, thousands of communities around Kenya, the PEPFAR program. So, it was a really complex partnership, but it ended up with a very simple and powerful result.
I didn't know that story. That's a really impressive story. And there are so many examples of how the companies, they really are part of these communities and the incredible work that they do. And I think you specifically mentioned working with families. It's not just the people who are walking in the door, but the good ones. Recognition that a healthy family makes a productive worker.
Another thing to reflect on is that, in Kenya, most of the people who work for AstraZeneca, which is a UK-based company, are Kenyans. So this is personal to them. It's really helping their communities, helping their country do a better job of dealing with NCDs. And so it really, what's great about putting these kinds of partnerships together is you can see the motivation from the company side because it has that kind of direct impact on the lives of people they care about. And so it's just another incentive for them to do this kind of work.
I want to thank you so much, Jeff, for coming here tonight.
Sure.
It's been wonderful hearing your stories. It's really, really exciting work that you do, and the partnerships you're able to build, here on Capitol Hill and across the world. It's just really impressive, and I know there's a lot of people who are eager to follow in your footsteps. So thank you very much. If we can all.
Thank you.